So I think we should get the day started, and our first speaker is Dr. Jim Wittig. He has been our chairman here for a bit over a year and has really made quite an impact both in the orthopedic department as well as the community. And we're really thrilled to have him. He's the director of orthopedic oncology and sarcoma surgery, and he takes really good care of his patients. I've known him for over 10 years and couldn't be more thrilled to have him here. So we'll start off the day.
Good morning, everybody. I also wanted to thank everybody for coming and attending the course. We have a fantastic faculty that are giving the lectures today, not only our own pediatric orthopedists, but many of our colleagues and friends like Dr. Douglas Avella and Dr. Avram Jaffe, who are here today, who we've known for many years. We encourage this to be interactive, so certainly if you have questions, raise your hands. And I just wanted to take a moment to brag a little bit about Morristown Orthopedics and what our goals are. We're really an orthopedic department that's an extremely busy orthopedic department. We have approximately 100 orthopedic surgeons on staff, and I believe about 10 pediatric orthopedists or so altogether. And there's really no condition that we're not taking care of here when it comes to pediatric orthopedics. We can handle from the simplest to the most complex, including now tumors and very complex scoliosis cases. So, and we wanted to share some of our expertise from everybody and also invite everybody who we probably regularly interact with so that we can meet everybody face to face and have a really nice day. So I encourage everybody to ask us, raise your hand, ask questions, or if you see us, in the hallway and you want to come up and speak to us about anything in particular, please feel free. So my specialty is musculoskeletal oncology, and I take care of quite a few children and adolescents with various benign and cancerous types of musculoskeletal tumors. And the malignant variety are naturally caused sarcoma. But, you always have to have a tumor in your list of differential diagnoses for anybody who's presenting to you with pain. Now, granted, this is probably number 20 on your differential, but you always have to have that in the back of your mind as to potentially being one of the causes of pain. Now, so just to give you an idea, sarcomas represent about 0.2% of all malignancies, or about 0.9 patients out of every 100,000 will develop a sarcoma. There's about 600 osteosarcomas a year that develop in the United States, and there's about 200 Ewing sarcomas. So obviously, very rare. Now, I don't have the exact numbers for the incidence of benign neoplasms, but there are various types of benign neoplasms also that should be within your differential diagnosis, many that are equally as rare. When we think about various causes of pain, we have to keep in mind both benign and malignant varieties. And in your benign category, you can actually have tumors that are either indolent and sitting there and doing nothing, and that perhaps patients were born with, like a non-ossifying fibroma, or benign tumors that are actually active and growing. They will grow, they will destroy the bone, they'll destroy adjacent soft tissues. However, they won't metastasize because they're benign. And by definition, the malignant variety metastasize. Not only are they locally aggressive and can destroy the local tissues, but they will metastasize. And this is just showing you an example of an osteosarcoma, the distal femur, where you can see it growing from within the medullary shaft, destroying all the bone in here, and spreading out into the soft tissues. Now, musculoskeletal tumors are classified according to the type of tissue that they resemble. So you have primitive mesenchymal stem cells that actually differentiate along various pathways and can actually begin to form various different types of connective tissues in the body. So they may form bone, and in that case, it's considered a bone-forming tumor, and there are benign and malignant varieties of that, such as an osteoid osteoma, an osteoblastoma, which are benign, versus an osteosarcoma, which is a malignant variety. They can form cartilage, so you've heard of enchondromas or osteochondromas, and then the malignant varieties are chondrosarcomas. These types of tumors that I've just mentioned are matrix-producing tumors. So if everybody remembers back to histology, generally speaking, your tissues in your body or your connective tissues are made up of cells and then the substance that they produce, or matrix. So for instance, tendons are fibrous-type cells, and the matrix is collagen, right? So similar with this. But we also have non-matrix-producing tumors where the tumors are just all cells and no matrix. And that would be, an example of that might be a Ewing sarcoma. This is just showing you how mesenchymal tumors grow, and particularly sarcomas. They grow in like a ball-like manner. And when they originate in the bone, they usually eventually, if they grow large enough, will penetrate the bone and grow into the soft tissues, and then they grow according to the pattern, according to the path of least resistance. They tend to obey fascial borders when they grow. So generally speaking, if a tumor grows from the bone and spreads out into the soft tissues into a muscle, your muscle is covered with fascia, it usually doesn't spread beyond that fascial boundary of the muscle. That's a little different than the adult carcinomas that you think about, because carcinomas will penetrate through fascia and are much more invasive. But these grow like ball-like structures, and on MRI can look deceivingly benign and deceivingly well circumscribed sometimes. So when a patient says, oh, well, it looked contained on the MRI, we know that when it's malignant, it's not really contained, that it's spreading beyond the area that you can see. These are your most common types of, I think, bone tumors that a pediatrician would come across, right? Your benign variety, including osteoid osteoma, osteoblastoma, chondroblastoma, osteochondroma, enchondroma, fibrous dysplasia, aneurysmal bone cyst, also called ABC, unicameral bone cyst, or UBC, and eosinophilic granuloma, or EG. And the most common malignant tumors or sarcomas would be your osteosarcoma and your Ewing sarcoma, although there are rarer types of sarcomas. Looking radiographically at these, you can see differences here. Up here is an eosinophilic granuloma. The interesting thing about eosinophilic granuloma is that it can occur in any bone and any location in the bone, and actually it can have various different types of radiological appearances. Can look very, very aggressive and be mistaken for a malignancy, or it can look very benign. This is a non-ossifying fibroma with a thick sclerotic margin around it. One of the characteristics that enable us to discern that this is benign radiographically. This is an osteoid osteoma where we see this small nidus, and it's caused a reaction in the bone where the bone is trying to seal it off. So you have a thick continuous periosteal reaction around it, trying to hold that at bay from growing, and rarely do they grow more than a centimeter in size. And then here you have a Ewing sarcoma of the humerus, where you see it's a very permeative lesion. You could barely see that lesion in the bone, but this patient broke his arm while throwing a football. Something that should stick in your mind, like, should somebody really break their arm just throwing a football? You take an x-ray. If the penetration of the x-ray isn't just so, or your contrast on your PAC screen isn't the greatest, you might not see that permeative lesion in the bone. So you have to have a very high index of suspicion. These are probably the most common soft tissue tumors that you'll see. Benign, including lipoma or lipoblastomas, hemangiomas, schwannomas, infantile fibromatosis, and ganglion cysts, and malignant varieties including infantile fibrosarcoma, rhabdomyosarcoma and synovial sarcoma, with rhabdomyosarcoma and synovial sarcoma being the most common soft tissue sarcomas that you'll pick up in the pediatric or adolescent population. This happens to be a synovial sarcoma here that initially was diagnosed as a very large ganglion cyst because it also had cystic features within it. But when you looked closely at it, you could see areas that were darker and enhancing, or the soft tissue component of it, which is the area that you would have to target a biopsy. So this patient was dismissed for a while as having a very large ganglion cyst. Just things to be aware of. So our clinical presentation of bone tumors include vague pain, swelling, night pain. Patients may present 10% of the time with a pathological fracture without any antecedent pain. Patients often have been misdiagnosed as having growing pains or having a sports injury. So things that you have to be aware of, that children who play sports also develop tumors. In particular, osteoid osteoma has a specific pain type pattern. It tends to have very severe, dull, aching pain that gets more severe at night and is almost 100% of time relieved 100% with taking an NSAID or an aspirin. So that's one of the things in the differential that helps us come up with our differential when we see the x-ray of an osteoid osteoma. And remember, the mechanism of injury must justify the type of fracture that's developed. So if you see somebody, a child stepping off of a school bus step and breaks their femur, or walking off the baseball field and collapses, or throws a baseball or a football and breaks it, you have to have high index of suspicion that there's something else going on in that bone, because sometimes these very permeative lesions can be very difficult to identify on an x-ray. In terms of soft tissue tumors, now this is counterintuitive. Sarcomas are usually painless. Soft tissue sarcomas usually do not cause pain. And that's one of the reasons why they can go misdiagnosed or underdiagnosed for a period of time. They're often dismissed even by the patient as a muscle pull or as a knot in the muscle. And counterintuitively, the benign tumors are usually more painful. Hemangiomas, schwannomas, they tend to cause pain. Almost all patients that have a musculoskeletal tumor can recall some form of an injury. I bumped my knee on the table, or I got hit with a golf ball in my shin, and then this mass started to develop. So you can't, again, you have to have that high index of suspicion and not just dismiss it as an injury, especially if a person has a palpable mass or swelling. One of the rules that I use is that if it doesn't get better within 6 weeks, that patient's got to undergo further imaging, with x-rays, and if you can't see something on an x-ray, you proceed to an MRI. And beware of diagnoses of hematomas based on MRI or based on ultrasounds. Some sarcomas can actually grow and be very hemorrhagic because they're growing rapidly and bleed into them internally and have very scant tumor tissue associated with them. And this is an example of a child who had an angiosarcoma, and you can see this is an MRI with gadolinium. There's no internal enhancement at all in this type of tumor, maybe around the periphery here. When we biopsied it, we aimed toward the more solid areas of it, and we're capable of diagnosing him with a high-grade sarcoma. But initially, he went 3 months as being diagnosed with a hematoma that was progressively getting larger. So again, high index of suspicion there. So your various different types of tests that are necessary include your plain radiographs. The plain radiographs are actually the best tests for your differential diagnosis. MRI is best for determining tumor extent. CAT scans are useful for subtle mineralization. CT of the chest is used for staging studies. Sarcomas most commonly metastasize to the lungs. Bone scan are useful for bony mets. The second most common site of metastases are other bones. And if you have uptake in the lesion, it might help you discern an indolent lesion from a more active lesion. Ultrasounds are absolutely no good for evaluating any type of soft tissue mass or a bony mass. They're notoriously inaccurate, and sometimes when they're performed, you end up getting an erroneous reading on it, and it delays the patient's ultimate treatment and diagnosis. This is just showing you a CAT scan of what a pulmonary metastasis looks like from a sarcoma. It tends to look like a nodule or a golf ball. Radiographically, what are we looking at when we evaluate a tumor? Well, you're looking at, the first thing you want to consider is the age of the patient. You want to think about the bone that's involved, because certain tumors occur in certain bones or in certain locations within the bone. Is that tumor geographic, permeative, or moth-eaten? In other words, what's the pattern of bone destruction? Geographic meaning that the tumor is kind of well circumscribed. Permeative and moth-eaten, you can't make out where that tumor begins and ends. Where's the location in the bone? Is it epiphyseal, metaphyseal, diaphyseal? Different tumors occur in different locations. And where is it in the transverse plane? Is it central, eccentric, coming from the cortex of the bone, or coming from the surface of the bone, or is it really a soft tissue mass? Is there any matrix mineralization, meaning is there any calcium deposition, or does it look like the tumor is actually producing bone, or is there ossification going on? So those are the two words we use, calcification and ossification, and there's some subtle differences. But that helps you place it into a category of either a bone-producing tumor or a cartilage-producing tumor. Cartilage tumors tend to have calcifications deposited in them, and bone-producing tumors tend to have fluffy, cloud-like ossification. And then you want to look at the is there any periosteal reactions? Are there benign appearing periosteal reactions, like we saw in our osteoid osteoma, where the periosteal reaction is continuous and around the perimeter of the tumor, or are they malignant appearing? And I think everybody remembers from med school the different types of periosteal reactions: a Codman's triangle, hair on end, sunburst type of periosteal reaction. This is just showing you a good example of a benign tumor on the left versus a cancerous tumor on the right. And you can see on the left, this is an osteoblastoma. It's growing, it's circular in nature, it's very well circumscribed, it's geographic. You can make out the borders of where the tumor begins and ends. It's actually destroyed the cortex. It has extended into the soft tissues. You don't see any cortex here anymore. But the periosteum has had enough time to react around the periphery of the soft tissue component, and you see this solid periosteal reaction around it. These are all features of benign. You look at this is a conventional osteosarcoma. You can't make out where that tumor begins or ends. You see Codman's triangles at the periphery, and you see this fluffy white-like substance being produced. Not only is there periosteal reaction, but the bone looks fluffy and cloud-like, indicating ossification. But you really can't see, this is the definition of permeative, you can't make out where that tumor begins and ends. Now, 95% of bone sarcomas will spread into the soft tissues, but there's 5% that are entirely intraosseous, and that sometimes you may not pick up on an x-ray. You need an MRI to see it. This is an example of a very subtle case of an osteosarcoma developing in the distal femur. And you can see this x-ray. If you didn't look over here at the periphery, or if the angle of the x-ray was just slightly off, you really can't discern much that's going on here. You might, in retrospect, look and see some little fluffy cloud-like areas. When you look at this, though, you see a Codman's triangle over here. That's a very worrisome sign. Then you get an MRI, and you see that there's something much more drastic going on in the femur. So, again, always have that high index of suspicion and correlate your physical exam with, very important to lay your hands on the patient and correlate the physical exam. This is showing you calcification. This is an enchondroma, an osteochondroma, cartilage tumors, and again, the fluffy, white, cloud-like density of an osteosarcoma. MRI is not very specific for diagnosing types of tumors. It may be highly suggestive with 4 different types of tumors, namely a lipoma, hemangioma, and schwannoma, and occasionally fibromatosis. But in the majority of cases, MRIs are not diagnostic. They could be highly suggestive. For high-grade sarcomas, Masses usually appear heterogeneous. The malignancies appear heterogeneous, but some malignancies may also have a cystic appearance, which you have to be very careful of. Gadolinium is useful for differentiating a tumor from a cyst. This is just showing you examples of high-grade types of sarcomas where you see a very heterogeneous mass with areas of high, low, and intermediate signal intensity. Looks pretty ugly, and that's because of all the necrosis and hemorrhage that goes on within the mass. Sometimes, again, I said these are read as hematomas by radiologists that may not have a lot of experience with sarcomas. This is an example of one that has a cystic appearance. Why does it have a cystic appearance? It's because the tumor is producing mucus, which traps fluid. And on an MRI, fluid is high signal on a T2 weighted image and low signal or intermediate signal on a T1. So these are called myxoid neoplasms, and they produce glycosaminoglycans or proteoglycans. And if gadolinium is not given with this, often I've seen these misdiagnosed as large ganglion cysts, which you have to be very, very suspicious of. So if you can't make a definitive connection with the joint, always get gadolinium and you will see enhancement of tumors. This is one that was dismissed as a Becker cyst in the popliteal fossa. It happened to occur in an area where a Becker cyst is common. You get the MRI and you see, oh, geez, this is filled with fluid. But the MRI was done without gado, and if gadolinium was performed, it would have enhanced and it would have been caught a lot earlier. Then, this continued to grow, and eventually the patient made it over to me. So just some specific types of tumors that you'll see. Non-ossifying fibromas, which are usually indolent, have a thick sclerotic margin. Usually they don't grow, but if they're big enough, a patient can sustain a fracture through it. So usually we're treating those that are at risk for fracture or for, usually at risk of fracture, or those that have actually fractured. They're usually diagnostic on an x-ray, and usually we're just observing them, but when they reach about 50% of the diameter of the bone, that's when a patient becomes at higher risk for breaking. This is a chondroblastoma. Chondroblastomas usually 99.999% of the time occur in the epiphysis. And you can see on a CAT scan, you can pick up the subtle mineralization. This is an osteoid osteoma, which usually has a small nidus, round and circular, and you usually get an associated periosteal reaction. Sometimes it might not be that visible on an x-ray, so a CAT scan can certainly help and show you the nidus. And nowadays we're treating those with radiofrequency ablation, very minimal surgery to eradicate the patient's pain. This is an intra-articular hemangioma that actually, from pressure, can actually start to erode the bone. So you see here the pressure erosion enlarging the olecranon fossa. And this is an aneurysmal bone cyst. Patient had a pathologic fracture through it. You can see here where the tumor has been growing and it's been expanding the bone, and an MRI shows fluid levels throughout it. This MRI is very characteristic of an aneurysmal bone cyst. The patient is laying on their back, so the sediment from the blood in an aneurysmal bone cyst settles to the gravity-dependent area, and you get these fluid levels. This is a gadolinium enhanced MRI, and you do not see any enhancement throughout it because the tumor tissue tends to be very, very scant in an aneurysmal bone cyst. An aneurysmal bone cyst is an active, aggressive type of tumor. It will continue to destroy the bone unless it's treated. So that's one that we don't keep an eye on. That's one that we go in and we absolutely have to treat. So it falls into a benign, active, or benign, aggressive category. Okay, so our treatment for sarcomas usually follows giving preoperative chemotherapy, performing limb-sparing surgery 95% of the time, and giving adjuvant or postoperative chemotherapy. These are the chemotherapy agents that are usually used for conventional osteosarcoma. It's cisplatin, adriamycin, and high-dose methotrexate. And for Ewing's, it's vincristine, adriamycin, Cytoxan, actinomycin D, ifosfamide, and etoposide. So usually most sarcomas, most bony sarcomas, are given preoperative chemotherapy. 95% of the time, particularly in this area of the country where there's relatively good access to medical care, 95% of the time the limb can be salvaged and saved. And then after the patient finishes with surgery, they're getting usually about 4 cycles of post-operative chemotherapy. And it follows the same for osteosarcoma and Ewing sarcoma. This is just showing you what happens when you give a patient preoperative chemotherapy for an osteosarcoma. This is an osteosarcoma of the proximal humerus, and you can see that tumor dies and then extensively calcifies in with the preoperative chemotherapy. So we can actually tell that that patient had a very good response to the chemotherapy before we even operate on the patient and examine the specimen. When you get a response like this, you know it's very safe to be closer to the tumor when you're doing your surgery as opposed to having to maintain an extremely large margin. So it enables us to save more soft tissue and make their functional outcome better. And that's really the main point of using preoperative. Here's just an example of a radical resection of an osteosarcoma, the distal femur. I just wanted to show you so that you could see the magnitude of the surgery, but then see what the outcome is. So, very big type of tumor. It's separated from all the neurovascular structures and the muscle, and I could tell on the MRI and intraoperatively what muscles we need to preserve to have good function of the extremity. This is what the specimen looks like. You could see a nice soft tissue margin around it of muscle. In this location, this is one of the 4 quadricep muscles. 3 of them are preserved. This is the vastus intermedius, which lines the tumor. So you take that out, you know that you have all the microscopic disease also. And then usually, majority of the time in this location, a prosthesis is used for reconstruction. These prostheses, especially for the distal femur, have a very lengthy survival rate. At 20 years, about 90% of these prostheses are still in place without any problems. So, and it gives a very good functional result. This is what it looks like radiographically. And clinically, this is, I think he was 16 at the time. This is his knee bending and extending 1 year afterward, able to squat down and able to, let's see. Tim, any way to get that going? I'm sorry, I guess. Well, I'm sorry, but you can see virtually normal function there. He's walking back and forth and has great function. You would never know that one side from the other. This is a Ewing sarcoma of the scapula, and you can see here the benefit of preoperative chemotherapy. This is a big mass that had developed, and there's no mass that's over here. This is another sarcoma of the scapula. And this is a patient from Albania who had an osteosarcoma of the upper humerus that was removed in Albania and the fibula put up there. When you take care of a tumor of the upper humerus, an osteosarcoma, you often have to take off a piece of the scapula with it because it spreads microscopically over there. They didn't do that, and he recurred with a mass around his scapula. So we had to go in. This was protruding through his skin. We had to go in and take this out, and we had to take his whole scapula out and put in what's called a total scapula prosthesis. This is just showing you the extent of the surgery where we're doing a lot of skin flaps and the type of prosthesis we would use for reconstruction. Then when we implant this prosthesis, we have to do a lot of muscle flaps around the perimeter of it to get it to work and close over with soft tissue. And this is sort of showing you intraoperatively what it would look like. And this is the x-ray. But this was the outcome about 6 months afterward. He was a little tiny little guy and had pretty good motion of his hand and elbow. Now the key to this surgery is you really want a stable shoulder girdle. After you release all those muscles and you take out all that bone and you take out the rotator cuff, a person's not going to have normal shoulder function no matter what you do. But you want to at least have a stable shoulder that they can use their hand and elbow. And remember, you're comparing this to a 4-quarter amputation, which would be the other choice for treatment. So, and this is about 1 year out afterward, with him having pretty good function, could lift up a little chair. I try not to encourage lifting more than 10 pounds. And what it looks like cosmetically. So you can shrug it. So has pretty good strength. And we always have them do party tricks. Push, push. So pretty good function. So he might not be able to do this, but he has very good function of his hand and elbow, which is the whole purpose of it. So that, because when you think about a lower extremity, if you do a below the knee amputation, you can replace that with a prosthesis. It's not perfect, but an upper extremity, you really can't replace a hand function and the sensation that goes with that. Thank you very much.